Hello everyone. Let us study the fundus findings in a patient of pathological myopia and understand why this degeneration happens. So, in a pathological myope, there is elongation of the actual length of the eyeball more than the physiological limits that causes the retina and the sclera to also distend. However, the choroid cannot distend beyond a point and thus undergoes atrophy. We should remember that the choriocapillaries of the choroid supply the nutrition to the outer layers of the retina. And thus, atrophy of the choroid is followed by degeneration of the retina and the vitreous that lead to the characteristic fundus changes in a degenerative myope. So let us see what happens in the retina. The retina outside the macula is particularly thinner in higher myopes. This retina is predisposed to degenerations like lattice degeneration and a cystoid degeneration at the ora serrata. Vitreous also undergoes liquefaction and degenerates. The macula in these patients, as we can see here, may have a macular hole. This macular hole predisposes the patient to develop retinal detachments, as here we can see a localized RD. A myopic macular hole is seen as a part of a myopic traction maculopathy or a myopic retinoschisis, and it is mostly seen in association with a posterior staphyloma. We should also keep in mind that the retinal detachment in these patients is difficult to treat as the retina is thinner. The sclera is also thin. This interferes with proper positioning of the scleral buccal. Also, these patients might have multiple breaks and the breaks might be more posterior. Moving on to the disc in pathological myopes is large, pale and tilted. The opening of the Bruch's membrane, which is between the retinal pigment epithelium and the choriocapillaries, shifts nasally. Also, the posterior pole of the eyeball undergoes elongation, and so we can see that the retina and the choroid are separated from the temporal margin of the disc. As this area does not have any underlying choroidal blood vessels, we can see the underlying bare sclera, and this is known as the temporal myopic crescent. Also, as the Bruch's membrane opening is shifted nasally, the nerve fibers have to override this opening to enter the disc, and this produces a nasal supertraction at the disc. The disc in pathological myopes is also more predisposed to developing open-angle glaucoma. So once the actual length increases, it produces a stretch on the choroid which cannot elongate. So we can see these cracks in the choroid. These are the rupture of the Bruch's membrane, known as Lacquer cracks. As we know, the Bruch's membrane forms a support for the choriocapillaries, and so once this ruptures, it can lead to hemorrhages. As we can see here, these are the subretinal coin-shaped hemorrhages. Also, the Lacquer cracks and areas of choroidal atrophy predispose the patient to developing choroidal neovascularization. So this is characterized by increased blood vessel invasion and pigmentary changes. These are common at the macula, and this pigmentation is seen in the form of a Foster-Fuchs spot. As they are common at the macula, they might even affect the vision. We should also remember that these patients can develop disuse atrophy of the ciliary muscle, as this myopia sets in very early in childhood, and these patients do not accommodate because of a high diopters of myopia. So as the choroid also undergoes atrophy, the underlying RPE becomes granular in the pigmentation. This allows us to see these distended blood vessels of the choroid. This gives the fundus a tessellated or a T-groid appearance, wherein we can see lines of pigmentation followed by blood vessels and pigmentation again. If this atrophy progresses, There is complete loss of the choroid and the RPE. So we can see these patchy areas of atrophy exposing the underlying bare sclera. Another finding seen inferior to the disc is this orange-yellow pigmentation. This is an acquired cavitation of the choroid known as peripapillary intrachoroidal cavitation. Moving on to the sclera, once the axial length elongates beyond the physiological limits, there is also an elongation of the sclera, which makes the collagen thinner and weaker. There is also a dehiscence of the lamina cribrosa in these patients. So the sclera elongates, but the radii of curvature of different parts might vary. This leads to producing areas of localized ectasia. This is known as a staphyloma. We can see in this that the superior part is densely pigmented, while this is the lightly pigmented inferior part. That is the staphyloma. The line of demarcation can pass through the fovea and lead to pigmentary changes. It can also pass through the disc and lead to a tilted disc syndrome or a rotated appearance of the disc. And so this is known as the inferior staphyloma syndrome or the tilted disc syndrome. It is important to remember that the degenerative changes in the fundus do not correspond with the extent of myopia, in the sense that a patient with even a myopia of as high as -30 diopters might have very less findings on the fundus. So these are the features seen in a patient of pathological or degenerative myopia and the reason behind them. Thank you for listening.